All right, everybody. So that brings us to the end of the TED Talks. We have now a good half hour or so for questions and answers. And I'd like to kick that off by posing a question to our panelists, and going to build or take a point from Dr. Bash's earlier talk and ask our panelists about the role of leadership in seeing their programs work at their local levels or in their states. And so two-part question. So, generally, what is the role of leadership in the programs that you presented today? And then secondly, at what level is that leadership most critical? State level, local district level, community level, school principals? Just curious, if you can identify where leadership is key. I think that would be really helpful in helping us understand, really how these programs work on the ground. And I guess anybody can start.
Is it on? Okay, good. So we are fortunate in Arkansas to have good support of leadership all the way down from the governor to the local school district superintendents. It's variable at the local level, but when we first started this, the governor at that time dedicated funding from that was available through an increase in our tobacco excise tax. That a portion of that funding went to provide for the cost of some of the flu vaccinations that we couldn't otherwise receive a reimbursement for. And that's been really key to continue to see these efforts grow. So thank you.
In Alameda County, it's important to have leadership at all levels. And so one of the things that we do is we want it from the superintendent level all the way down to the site administrator level. We have master agreements with a couple of our school districts, and our goal is to have a master agreement with all 18 of our school districts that are board approved by our board and approved by the school district's board about defining the parameters of our relationship. And so this kind of sets the standard that we're going to be working together and have these kind of common agenda and common goals. So it really has to start at the highest level. But at the service level, when you're delivering, you actually have to have the buy-in of the site administrator. You can't just make deals with teachers and things like that and implement a program. It will work as long as that person is there, but it really has to have some institutional memory. And so at that level, we do letters of agreements every year about the relationships of all of the providers that are in the school setting and what they will exactly do.
In our case, I think I agree with all the things that have been said. I'll say on the clinical side, recognizing how busy clinical teams are, we identified early on a need to be sure we had clinical champions in each of the participating clinics, ideally with dedicated time, because we all know we can have great passion for something, but if we don't have dedicated time, which we've written into some of our philanthropic and other grant applications, that sometimes that passion might peter out as other competing interests come about. And so that's been something that we've spent a lot of time focused on and will be a big part of our engagement moving forward.
And I think for our Vision for Baltimore program, I would echo everything that's been set up here already, but one of the unique things that we tried to do was come together as a city and come together thinking about vision issues from the Department of Health, from the city school system, but also from a leading academic university in the city, and in thinking collectively what are the strengths that each of us have that we can come and try to address this problem and bring in our optometric and our optical provider partners to do that. I would have to second Kimmy's point as well that engagement, stakeholder engagement at every level is also as important as leadership, because there are a lot of good ideas, but trying to execute them in practice on a daily basis in a busy school setting, similar to what Heidi's saying about clinicians, it can always be a challenge. And there are things that I thought were a great idea, but then when it gets into translating into the actuality of what's happening in the school can be a big struggle if you haven't built those relationships at the school level, which the leadership has helped us be able to effectively do.
Wonderful. Okay, so we can take questions now, please.
Great. I don't know if, is this on? I'll assume it is.
It is. And if would you specify if it's for everybody or for one particular speaker?
Sure. So my name's Kelly Hall. I'm a health policy consultant, former Obama nerd. And my question is for Heidi. I was really excited to hear about your success in data sharing around absenteeism. And one of the things that I am thinking about is how we get healthcare providers to have the both interest and the tools they need to pay attention to educational outcomes, especially in sustainable ways. I know you mentioned some of it is grant funded, and I'm inspired by some innovative employers that have been thinking about holding their insurance companies and provider partnerships accountable for work absenteeism in their insurance products. I'm wondering if you've thought anything about the possibility of sharing school absentee data with either employers or insurers, especially in a market where there may be consolidation of some of those employers, whether there's ways we can use those points of leverage to get providers and other stakeholders held accountable for kids being in school.
Yeah, it's a great question. Thank you for asking it. We haven't talked on that yet in this discussion, but I know many folks in this space. I'm reflecting on folks at the Rail Center in Baltimore. I've heard them share one of their metrics that they're looking at, and a potential opportunity to leverage additional funding is to think specifically about that. In that case, kids using the school-based health center in the school means that parents don't have to miss work. And is that a way that we can sort of all coalesce around the cost-benefit analysis and need for investment in the programs? But it's a great question.
I'm Rochelle Davis. I'm president and CEO of Healthy Schools Campaign, and it's kind of a slight variation on her question for everyone, and then I had a specific question for Heidi, which really is about funding. I mean, how many of your efforts are really based on philanthropic dollars as opposed to kind of more sustainable and more renewable sources of funding? I mean, nothing is forever because it, it's based on federal policies, but, efforts that are totally based on philanthropic dollars, are not necessarily going to help with the system level change. So if people could speak to that funding sources for your initiatives.
Sure, I can start. So for our program, it's a 3-year pilot program, and we recognize that to get things off the ground, we were going to need the support of philanthropic dollars to help us get things started. But with an eye towards sustainability, we began very early conversations about financial sustainability, particularly with creating an infrastructure to bill Medicaid. And that's been successful. And we're in our 2nd year, and we're actually billing Medicaid for a reasonable portion of the students that are seen.
So obviously philanthropy is very important, but like if you look at our county health budget, which focuses on disparities, it's probably $700-800 million a year. And this work is never going to be sustained by without public systems actually owning in and buying into this. And so similarly, we use our tobacco master settlement dollars. We're a little different here in Alameda County. We're willing to tax ourselves, so we have a sales tax. So we invest, I think, about $17 million a year in just I gave you one example of school health centers in our school health program. So yeah, it really takes the leadership of our electeds to invest, flexible dollars and to implement models like this.
So I think one of the things that's exciting about our program is that the infrastructure is there. The health information exchange exists already has connections with the clinicians. And many of the other pieces that we're putting into place are low or no cost, specifically consent forms. Our registrars are already entering data into our student information system. And so I think from a long-term standpoint, we're actually well situated to be able to move on this with minimal, if any, money. The biggest need for funds for our pilot is really the evaluation and for some dedicated time for our clinical partners. And that, I think, as we come to scale, may continue to be a need, or as systems get more put in place in the clinics, I hope that will sort of just become a basic part of their workflow too.
The effort that I described for state vaccination was not really done with philanthropic funds. We do receive grant funding for our immunization program through the CDC, but much of the vaccine is paid for through the Vaccine for Children program, as well as the state child health insurance program. We bill private insurance when that's available, and then we use state general revenue dollars to make up the difference.
Well, thank you. And just really quick for Heidi, you talked about sharing attendance data with clinicians. Are you also sharing or looking at sharing health data? Because we know that as we moved in this country to an electronic health records, to health data systems were missing schools and prisons. And I'm just wondering if that has created more of a barrier.
It's a great question. We're not talking about that yet, but I think we hope that this conversation opens the door to a lot of other cross-sector data sharing opportunities.
Is Jill still connected to us? I just want to make sure we didn't leave.
I'm here.
Okay, I just want to make sure you have an opportunity to weigh in here. I apologize if I didn't call you out.
Thank you. No, that's fine. I'd like to just make a quick comment on funding. Our programs have been funded by research grants. However, they've really been purposely designed in hopes that the use of existing parts of the infrastructure can be sustained. And when we've worked with other programs that have been implementing similar types of programs around the country, we've really tried to help them capitalize on what they already have in their own communities to make sure that they're sustainable systems that they're building.
Great, thank you. Next question.
My name is Lindsay Morris. I'm here on behalf of the program Too Small to Fail. And this is a question generally for all of you. I'm interested if each of you can speak a little bit more about the underlying roots of a lot of these chronic absenteeism, asthma, etc. One of the things that particularly called out to me during one of your presentations was in relation to kids of color more likely living with asthma. And I want to know if you could talk a little bit more about why that is. If we reflect on air quality, what are your departments, agencies, and organizations doing to address air quality for kids of color and more of these underlying roots and causes of the issues that we're seeing in communities today?
So that's a great question that I don't really have an answer to because the causes for disparities in asthma are really thought to be multifactorial, but there are certainly environmental triggers that we know make asthma worse, including pollutants in urban environments and allergens in the homes and ongoing exposure to smoke. And these things are really difficult to get on top of. There are many programs that are trying to address the environmental causes of asthma. And it's tricky because many of our families, if we work to remediate the triggers in their homes, may not be in that home for long. A lot of our children are in between multiple homes or may move frequently. So it's very difficult. And there are also some data that a lot of the allergens are actually in their schools. So thinking about how to address environmental exposures in all of those areas is really important. Most of our work has focused on preventive medications, in part because that's the low-hanging fruit. We know that they work. We know kids aren't getting them, and so we're trying to link those systems of care to make sure that we can close at least that gap. But the rest of it also can't be ignored, so you bring up a very important point.
As far as vision, we know, and I think Dr. Bosch alluded to this data too, the epidemiologic data is not great, but it looks like about 20 to 25% of kids have vision problems, most commonly being nearsightedness and farsightedness. So most of that is correctable. I think one of the big challenges in accessing vision care is most kids are largely asymptomatic. So they're not going to tell their teacher or their parent, I can't see. So that means that things get delayed for a long period of time unless they're recognized through vision screenings. But we know that there's significant disparities in vision screenings actually happening. So if you're in a high poverty school, it's less likely to happen. There's great data about, whether English is the primary language in your household, what the household income, the highest education level, all of those will impact whether kids actually have a vision screening in the first place. That also then plays out into whether or not they'll ever go to have an eye exam in the community. And also, actually, we think, although we don't have all the data back on this yet, we also think it impacts whether they would actually participate in a school-based program too.
I just want to add that this is in a school-based setting. It's also complicated that the external factors that are apparent to teachers and educators for these young kids could be asthma or vision problems, or it could be dental decay, but it is actually seen as a social emotional problem of acting out. This is a crabby kid, and it turns out they're in pain because of their teeth and things like that. And so, and that has to do with, the interpretation of the kid that's in front of them. And lots of times race plays a big factor in that. And so it is very complicated for this kind of early identification of kids with any kind of health conditions being identified correctly.
I mean, I think it also speaks to the importance of district level and school level early warning systems that aggregate school-based metrics that we have, access to and control over: absenteeism, behavior, course completion, using that data to figure out, so it's not just the crabby kid, right? It's like getting deeper at the root of the problem. Those tools exist today. And so it's, really incumbent upon local communities and state communities or states to take advantage of those resources so we can start moving the needle on those root causes.
Hi, Jeff Levy from the Roundtable and George Washington University. So there's another finance side or money side to this equation, which is for many of the interventions we're talking about today, we're increasing school attendance. And so I'm wondering if any of you have looked at the enhanced revenue that school systems have received by increasing average daily attendance.
We are just starting a cost analysis looking at both programs that we're involved in Baltimore and Chicago to look at a cost-benefit analysis, but we don't have any of that data available yet.
One of the metrics that we look at with our client visits in our school health centers is where they sent back to class, because because they can be diagnosed and treated. And so, and I can't give you the numbers right now, I have it in my report. It's between 80 and probably 90% that are sent back to class. And so then when you calculate that to the average daily attendance, that they weren't missing a whole day of school to go to their provider, it's, it's close to $1 million that is saved or earned from the ADA.
Yeah, at the district level, certainly there are lots of folks looking at that, but we haven't talked about that with this pilot yet, but we should.
Well, and you're getting at something where we would like to go. We're fortunate in Arkansas is that all of the school districts use the same database system. So we're able to look at state level things, and that is something that's relatively new. We have a developing partnership with the health department and the Department of Ed to look at the data and how can we address the HIPAA and FERPA issues to get at that. We're making good progress, and I'm looking forward to seeing what we can show with it, because that will certainly drive decision-making and policies.
Yeah, and I'll just say some little bit more historical data. I mean, it's a great point. I think political will was mentioned earlier today, and for better or for worse, money talks, specifically among our politicians and our electeds. And I would reference everybody to the E3 Alliance in the Austin, Texas area. I think it was about 2 or 3 years ago. E3, in collaboration with the local hospital system, ran, I think it was at the time, the largest flu vaccination campaign in Texas state history. And in that year, they calculated that the days saved or the days not missed among students that were covered in that campaign amounted to over $20 million in monies back to the schools, and that is not an unsubstantial amount of money. So I think we would be well served if we could, not just around absenteeism, but a whole range of issues, really figure out that cost-benefit analysis for our local stakeholders and leadership, because at the end of the day, that's going to be a big part of the answer here.
I don't know if Dr. Halterman wanted to add anything?
No, we haven't been able to put an exact dollar on the value, but we certainly hear consistently from the school district that it's a priority for them to reduce absenteeism. And to be honest, I think that's one of the main reasons we've had buy-in to our programs, because they view it as a significant problem to keep those kids with asthma in school because they want them to be learning. So I think that's a great point, but I don't have exact numbers.
Great. Sounds like something to follow up on, Josh Sharfstein. My question is a little more amorphous, but all of you are working in this area that's a little bit unusual in general for health to be really focused on education and providing results to the education system. As you talk about this or try to seek funding for it, who are the people who really get the idea that this is a value, and where have you run into resistance for people to understand, well, why are you doing this? I don't understand. I'm just curious, where are maybe unexpected sources of support as we think about like the issues of how to get more support for it? Just what are the experiences that you've had, positive or negative, in trying to explain the value of this?
Well, I'll start. I think I'm lucky in that because our focus is on chronic absenteeism specifically, which is an sort of edu-speak term, I have natural buy-in, I think, but I'll say what's been interesting is I remember a colleague of mine early on in this said to me, why do pediatricians give a hoot about absenteeism? And so helping folks understand why the child health community is interested and cares about this actually has been an interesting sort of translational exercise for me. But I think I'm lucky because our end goal is already a concrete educational term.
I would say, and I think is demonstrated in the room when I put up that first slide that looked very blurry, fortunately, difficulty with vision is something that people tend to get, and they do appreciate the simplicity of the intervention, which is essentially giving children a pair of glasses. I think where we are strategizing about how to optimize our intervention is that schools have so many different needs for interventions, whether it's asthma or allergies or immunizations, health, dental, anything like that. So they have so many different people coming in and offering these interventions, and their bandwidth gets exhausted at times. So I think the more we start thinking about synergizing between what's happening in asthma and what's happening in vision, I think the more effective we will be.
Hi again. Oh, go.
Oh,
Kimmy.
no, I wasn't saying. Go.
Yeah, okay, so Kimmy knows I'm so jealous of Alameda County, but my question actually is for you, Heidi, around the consent forms. Were they opt-out? And, yeah, they were.
No,
No.
they were opt-in.
Okay, that's interesting for me too. And so it was to give the pediatricians the information about the students, correct?
Correct. So the form, it was a simple form, and it's one-time consent, so we don't need an annual recertification, which was a big win. It is a simple form that says that the family gives consent for the District of Columbia Public Schools to share attendance data with, I think it says, quote, my child's pediatrician and medical team, or something to that degree.
Yeah, we're working on a database that's an intersection between the providers of the wellness centers and attendance and academic records of the students in LA Unified de-identified. So we just really want to look at population health. So it wouldn't be a consent, it would be agreement with the district. But one of the things that we're working in our oral health program as well, and Dr. Dudovitz from UCLA, who's a pediatrician, who's evaluated the oral health program, we know 2.2 days of school is missed due to dental pain. We know what level of pain we have for kids. So we're giving kindergarten report cards to the principals where these kids are screened saying, this is an estimate of the number of days that you've saved. But I want to share her quote with you that we should really be looking at academic performance and make that the fifth vital sign.
Mm-hmm. Love that.
Sandy Magnan again. This has just been a rich dialogue here, thinking around health and healthcare and how schools can work together. So I want to push on what Josh said just a little bit further with the question of, so if there would be something else that you would say, boy, I would love it if healthcare would like step up and help me with this in my school setting or in my thinking about interacting with the schools. And my mind kind of came to like, okay, asthma is a chronic disease. What's the next biggest chronic disease that kids struggle with in school? I'm not a pediatrician, so I don't know what that is or whatever. But anyway, that concept of, boy, I'd love it if the school, if healthcare would step up and help me with, what would that be? What would you say?
I can start. I'll say this is a few steps from starting with schools, but I think our data has shown us that it's not only the health of the children, but the health of their families hugely impacts attendance and academic performance, and specifically mental health of parents, especially in certain communities. I'm reflecting in the communities in which we're doing our pilot. We have a large immigrant population, and the trauma and mental health concerns within the parents and families has been significant, and so I think that's a real opportunity.
Hi, my name is Phyllis Meadows, and I'm a member of the Roundtable. And don't worry, Kimmy, I told her I was going to ask her a question. This could be you, this may not be you. So I've been struggling a little bit with how to phrase this, but I think it's more of a bandwidth question. Building it on some work that we've been doing in Detroit, and what's come up quite often is the pediatric community and their failure to follow through on some of these very important screenings. And so I kind of want to know what's with that. And with recognizing that they're getting asked to do everything, now the ACES stuff. And so, are there some strategies that we need to be thinking about to support pediatricians who are really an important place where children get well baby care? And how do we do that if that's possible? And then the second half of that, or the corollary question is, you have educators who are there to educate our children. And I come from an educator family. So first thing they say is, that's not my job. Now, I argue with that because I'm a health provider, but they are challenged with educating children. They have a lot of standards and objectives they have to meet. So, how do we balance that with a role that they need to see the whole child, but also the bandwidth issue on both ends?
I love that question, and I would be interested in hearing from some educators about their thoughts on that. We've been doing, over the past year, we've done 40 focus groups with parents and teachers between Baltimore and Chicago. In every single focus group with teachers, we asked them that same question, sort of how did they feel about the fact that there's so much of healthcare that's encroaching upon what they do in the school system, and having ownership in that realm. And almost universally, they are appreciative of the fact that there are opportunities through programs like the programs we're talking about today to help kids out in schools, because they will say, I'm accountable for how they're doing on their park testing or their absenteeism and everything else, and they're not doing well because they don't have a pair of glasses, or they're absent again because of their asthma, or they got the flu. But now that we have things coming into our school that give us more tools that we can help with this, they seem appreciative. But I agree with you that there is, at some point in time, and this sort of goes back to the way of thinking collectively of how can we combine all of these different health priorities, maybe that Dr. Bosch talked about earlier, and think about working synchronously rather than siloed.
Well, I can't help but bring this up because I sit on a different roundtable. I'm on the roundtable for health literacy. And as we've already seen, there's a lot of impact here. So the parents who get the letter from the school that they really can't quite understand and they don't know how to navigate and make an appointment and then follow up. And the pediatricians who try to reach out to the parents but do not have the resources to educate the parents about how to manage the health of their child. I think we really do have some big health literacy issues here, and I think there are opportunities in the school setting, particularly in the school-based health clinics, to help bring the families on board and work with them to develop the skills to manage their children's health. That's a skill setting or skill building opportunity. And I think working in partnership with the pediatricians is a really key part of that.
One thing that I want to add, I mean, early on when we started doing this work in the schools, a lot of times the schools would like send kids out of the class to say, here to the multiple providers, please, can you help them so that they can sit in class. But now one of what we do is that we are rolling out coordination of services teams across the districts in the schools so that referrals come into a team of providers and different school staff and principals or vice principals to look at the issues that is bringing the student to the cost team. And we, to avoid trying to send kids to get fixed, we sometimes send mental health providers or social workers to work with the teacher and provide teacher consultation on how to work with the student. And so as that happens in that relation, because it really is about relationship and trust and how to work together. It's about being a we and not an us and them, really.
And I'll add one thing as an educator. I think it's tremendously important that we avoid what I'll call the lasagna effect, where we're just layering things on top of one another and expecting that either it's going to penetrate the deep sediment of our education system, or that we got to blame and shame and hold teachers quote unquote accountable for not doing new things when we're not alleviating the pressure of all the historical things or all the existing things that we've been asking them to do. So I think it would be helpful if everybody or anyone in this room who has any contact with educators and you're working at this intersection of education and health, that you help school system leaders and educators understand the existing opportunities within their within the routines, within their existing school day, within the course of their normal job opportunities, to say this is where you can amplify the effect of your work to improve not just the health outcomes of your students, but also their educational outcomes, the outcomes by which they're being held accountable or for which they're being held accountable. So I think it's important that it's not just about the new and the faddish or the most effective, but it's about how do we leverage existing structures most efficaciously so that we can help our educators, frankly, transition away from this fixing kids idea to it's my responsibility as an educator to address their needs in a holistic fashion.
I think that lasagna effect plays out on the clinical side too.
Okay. And one more question.
Thank you. My name is Ihuoma Emenuga. Can you hear me? Yes. And I'm from the Baltimore City Health Department. I'm the medical director for school health. And something that Kimmy said earlier really struck me, and I've been thinking about it all morning. And you talked about the fact that you're not just trying to change the kids, you're trying to change the families. And I thought to myself, for many years, the World Bank, the World Health Organization, has talked about the cost effectiveness of female education and how it affects almost everything in public health, much more than all the interventions we spend money on. And, when she just asked a question about if you were able to do one more thing, what would you like to do? And Heidi said, intervene with families because what the things affected there. So I guess my question is, the evidence for the return to schooling or return to education is very significant in developing countries, maybe because it's been studied more there. I don't know that I've seen that much information for developed countries, but I don't have any reason to believe that it would be different. And so I look at the interventions that were talked about earlier. I was really intrigued by Dr. Bosch's presentation about the 8 different areas and how they were almost symptoms, and then they went into mediators, which he grouped by 4. It looked very schematic to me. And as I looked at these things, it looked very much like the kind of interventions that could be addressed at the level of female education and the return to schooling in that way. So my long-winded question is there any way, could you consider, I guess anyone else in the room, how do we build an initiative that can give us that amount of return on education at the level of families, and maybe more specifically, women and mothers?
Great question. No, great, important question. I think in the vision realm, what we recognize over and over again is it's just not a point of service intervention, and it really is changing a culture. And as I said at one point in time, it takes a village. It's not just the teacher, it's not just the school principal, it's the teacher, it's the students, it's the parents. Collectively, when they all get on board with some type of health intervention, working together, they get it. It's the kids who are, sort of having a peer influence on each other about wearing glasses, or reminding their parents, oh, hey, I want to get my eye exam at school. Can you fill out this form? I think the place that I worry about with school-based delivery of care that sometimes gets lost is the parents, because there's direct communication often between the student and the provider and the teacher, but not always back to the parent. Or it will go to the parent, but it's the same issue as before, health literacy, that they may get a form, but they don't know the significance of that. So I think the onus is on our group when we're doing these type of programs to figure out how to effectively engage parents. And what we've found, one thing that teachers tell us is we need to, again, kind of incorporate ourselves into other things that are happening at school. So whether it's report card pickup day or back to school night, build in health awareness, education campaigns, at things like that. I think parents will respond, but you have to find times where they're going to be a captive audience to get the most impact.
And I guess what I would add to that from a public health perspective is that there can be no wrong door, and so that we all have to be communicating and be aligned. So whether it's the youth center down the street that's doing something with the families and the young people, or it's a dental health initiative or whatever it is, we have to be communicating at the level and include the schools as a partner in how these public health initiatives are designed in the communities around the schools.
Great. Well, this has been a fantastic panel. I learned so much. Thank you very much to everybody here to my left, and Jill virtually. Let's give them a round of applause. And before I turn over the microphone, I'll just, as the co-founder of the Middle School Kindness Challenge, I want to leave everybody here with the challenge and acknowledge, if you're sitting in this room or if you're watching this online, you're on the vanguard of this work in this country. And I think it's really important, since we know from cognitive science that people learn most powerfully through the act of storytelling. I would challenge everybody in this room to identify and develop at least one story with the name of a real child or a real parent or a real somebody that you can be the broker and tell the story about why this work is so important. And the more people we can tell these stories to, the more people will begin to believe us that this is really important and impactful work. And when we do that, I think we're going to be able to amplify not only our voices, but the power that we have to change not only the metrics and the outcomes of our children, but ultimately the culture in this country that leads to the kind of results that we don't like. So think about that, resolve, in very short order of time to develop that storytelling ability around this work, and then that'll amplify your ability to make a difference. Thank you very much, everybody.